First of all, I'd like to thank the King Khaled Eye Specialist Hospital and the education team here for inviting me. It's always an honor to be with you and to share some of the information and to collaborate with colleagues, especially here in our region, which I think is very important, especially in this area of residency education, an area that's changed significantly over time. And it's an area that's really, I think, has become very important worldwide and an area of concern worldwide. The significant changes have been happening, and I think it's important for us to understand these changes and decide what is important for us and to keep up with these changes. So I'll be talking a little bit about this topic because, again, from a standpoint of a national standpoint, it's really become imperative for us to make sure that we're providing our residents with the highest quality education. I consider it a national duty. We've accepted these residents. We've accepted to train them. And for us, they are the future of medicine. And personally, these young doctors will be taking care of us one day when we are older, taking care of our family, our children. So this is a topic I think has become very important in addition to, of course, all the clinical areas. And we'll show some of the reasons why that is important. Briefly, we just would like to acknowledge the Royal College of Physicians and Surgeons of Canada, who provide a lot of the material freely to us. A lot of the clinician educators from the CanMEDS Collaborating Center who work on many of these presentations, who I'm summarizing for you. And the American Board of Pediatrics also very kindly shares a lot of their material, and many of that is available online and can be available as a resource to you if needed. Before I start, has anyone attended our workshop? I know the residents from the ophthalmology program attended our workshop at the National Guard King Abdullah Children's Hospital. Anybody attended a CanMEDS workshop before? With the Royal College, or how about at the AME or ICRE? Anybody program directors here with us? Any of the program directors today are with us? Yes? Okay, your program, okay. Excellent. Okay, so has anybody heard of CanMEDS before? Who's heard of CanMEDS? Okay. Excellent. Well, where did you hear about it? When? هل بس يعني من السعودي كوميشن أو من وين سمعتوا عن الكانميدز؟ هل هو ولا من الحديث يعني الحديث المجتمع حديث الطبي؟
This is part of the skills that any medical student or the postgraduate student should fulfill.
True. Absolutely. But has it been discussed here at KKESH and it's been discussed, have people begun discussing about these skills or still in the early phases الآن؟ أو دكتور أنت برضو قلت you heard about CanMEDS أو from discussions. Okay, fair enough. No, this is an introduction really. The objective is really to introduce this. We gave this as a workshop, and I told our colleagues, Dr. Tariq and Dr. Adil, that we often and we prefer to give this as a full-day workshop, which we gave to the ophthalmology residents, I think a couple of months ago. I think it was in February or earlier even earlier, November, مر الوقت. And that's our preference. It's a hands-on, and the idea is to hopefully you grasp many of these skills that are important for our residents to understand. So I'll go ahead and get started. Again, it's an introduction, and we often like it to be hands-on, so I'm happy to take questions either throughout or at the end. So for the main objective, mainly for this brief introduction, hopefully the next 40 or 50 minutes, is mainly to understand the rationale and need to change. Why CanMEDS happened, why it's happening worldwide. CanMEDS is only one of many others, and we'll just touch upon the others. Define and describe some of the CanMEDS framework, determine some of the significance of these non-medical experts, and this is probably the last time I want to use the term non-medical expert. We use a different term for it. And outline some of the various teaching methods, which probably time will not just allow us to do, but maybe in the questions or maybe in discussion. As you can see, of course, it's not a clinical presentation, but it is very important. When we talk to our residents about acquiring these skills, it is something that has been proven, and again, time will not allow us to show all the literature, but proven that programs that apply these skills, or we call them competencies, their graduates do better. And that's just a simple term. And how you define better, whether it's patient outcomes, job satisfaction, etc. There's so many criteria to show that implementing skills other than the pure medical expert skill results in better programs. So what is CanMEDS? It has a definition. It was called the Canadian Medical Education Directive for Specialists. Well, we don't do that. They don't use that anymore now. That term is not used anymore. But it came from this. In the 80s in Canada, there was a dissatisfaction with the performance of physicians. And then in 1987 in Ontario, there was a physician strike. Some of you may have heard of this if you read the medical history. However, there was lack of public support. In the media, everyone sort of was against the physicians. The physicians, of course, were shocked and disturbed by this. They solved this, but they developed the educating future physicians for Ontario, the FPO, and nationally, the Royal College of Physicians and Surgeons of Canada developed the CanMEDS in 2000 project. So you can see it's been going on for over 15, more than 20 years actually, this project. But it came from that concern, that societal concern. Residencies were considered to be periods of training. The goal was to produce medical experts. And by the way, we do a wonderful job in this. Even locally here, most of our residents who travel abroad do an excellent job when they go into training programs in North America or in Australia or in Europe. When it comes to the medical expert component, whether it's answering the exams or so on. But when it comes to other skills, our residents and other international graduates are lacking. Many programs in Canada, for example, require certain workshops pre-starting, pre-residency for a resident to go into a program. And these workshops are not about ophthalmology or how to do your procedures or so on, or differential diagnosis of glaucoma or whatever. It's about other skills that they feel residents, international graduates, are lacking. So the way we train or teach our residents has evolved. So this CanMEDS that we're talking about today is a needs-based, and this is an important term. We'll come to where these needs came. It wasn't just simply PhDs or doctors, educationalists saying, you guys are doing it wrong. They did play a role, but it's a framework, and I should probably highlight this. It's a framework of things that probably many of you do. As these slides go through, you'll see that many of these things you probably practice. But what they did in Canada, North America, and the ACGME, and Europe, and the UK, and Australia, is they put it in a structured framework, a framework that can be easily or relatively easily, I don't want to use the term easy because it's not easy, but relatively easy to put into a curriculum and then to apply it and assess it. Of physician competencies, skills is a term we often use, but competencies is the accepted term now. And the first of these competencies is easy, medical expert. No doubt that you want to graduate your residents to be great clinical ophthalmologists, to be able to diagnose ophthalmological problems and to manage them and to be good in the OR and so on, and to cut. But the problem was, and this again has been proven, that it was simply not enough. So what were these needs that we're talking about? Sure, there were the experts, the educationalists who said that's something that has to be done. You're teaching your residents different. You're falling behind compared to other specialties like engineering and other expert fields. There were the perceived need, physicians and trainees, ourselves as consultants. This is something, and I think, and I see it here in our own institutions and programs. The Saudi Commission are not happy with our residents and their performance, and it's not necessarily their fault. The trainees themselves felt they were not necessarily getting what they needed at graduation to practice real-life medicine. And then institutional needs. Residents find out when they graduate, almost from day one, that most institutions need something more from them to simply see patients. It's simply the need of today. They're going to be on committees, morbidity, mortality committees, capital equipment committees, other requirements, even probably right from day one. We have some of our fellows who come from the Ministry of Health. As soon as they go back to their hospitals from some of the other regions, they're immediately put in administrative positions because there's a need. Societal needs, and there were concerns. And I think many of you, have already felt how things have changed in our society when it comes to issues of al-akhta' al-tibbiyya, malpractice, whether it's justified or not. But it's something that's happening in our society, and our society seems to be asking more of us. So what other competencies are there? And this is a question, we put this in our workshop when we discuss it. Is it enough to pass the test? This used to be, when I was training, this used to be king. The written test was the big thing, that if you were the best on your written test, you probably were going to be the best physician. Well, this is proven wrong, and we discussed this in our workshop. This is proven wrong. What other competencies are there? Well, there are many. And again, we don't have time to go over it interactively, but these are the CanMEDS competencies in addition to the medical expert. The communicator role or competency, domain of competency. And these are terms that you'll be hearing from this Royal Commission. If you decide to work with them or collaborate with them, terms you'll hear from the ACGME. The communicator role or domain, the collaborator, health advocate, manager, scholar, and professional. And again, if we have time, we'll touch upon, these are just broad domains of the framework. And underneath each of these have specific definitions and key competencies that then go into your curriculum. So communicator is the relationship between the physician and the patient, and all that entails goes under that. And there's several key enabling competencies that go under that. The collaborator role is that relationship between the physician and other healthcare providers, colleagues in the same field, or other allied health professionals and so on, nursing. Health advocate. As physicians, whether we like it or not, our patients, we require that we advocate for them, whether at the individual level, and as a pediatrician I can relate to this. Advocacy is speaking for those who don't have a voice. That's one definition. And for us, children are the most in need of advocates, in addition to advocating at the community level and public health needs and awareness. Manager, and this has changed to leader, and I'll show you this in a minute. While not all of our residents are going to be directors or CEOs or chairmen, but they do, and the Royal College has felt that every physician does play a leadership role, whether it's in a small team in a neonatal resuscitation room or in OR or so on. And scholar, the components of lifelong learning, evidence-based medicine, teaching abilities, the ability to teach, all these go under the scholar. And then finally the professional. So many key competencies go under that. Integrity, honesty, ethics, maintaining our standards, abiding by our own Ministry of Health laws, and so on. Participating in physician-led regulation. Those of you who are on Saudi Commission committees, you are being professional by working on those committees. And physician well-being. This is something the Royal College now has added in the past few years, that residents have to learn how to take care of themselves, and physicians, otherwise they can't take care of their patients. This is just a brief summary, and if time allows, we can go into more detail, which I suspect we won't have time. So the concern was, it was not enough to be a medical expert. That these 7 competencies were the descriptions of the abilities of the whole or complete physician. And this is the 2005 framework, just last October at ICRI, and I highly recommend, if you are educationalists, to attend either the ICRI, the International Conference on Residency Education, or the AMI, not related to the Royal College, but both are excellent educational conferences. But they rolled out the new framework. The big change was manager change to leader, and some of the changes that happened to the key competencies under each of these. And as you can see, the medical expert is the central role, a central part of the flower. They all intersect. Communicator would intersect with collaborator in real life. No doubt, to collaborate with your colleagues, you have to be a good communicator. But this is the graphic description of what I've been describing. And this is a question that I think we have to define terms, because that'll be required of you. And the Saudi Commission is coming. I'm not sure where ophthalmology is, but I saw your ophthalmology curriculum, and CanMEDS is full of that. I don't know, has anyone, have you all seen the new ophthalmology curriculum from the Saudi Commission? No? I think ساكتين ما ادري لو حد رافع يده يمكن ما حد يرد عليها. Anyway, you should take a look at it. It's a very well-written curriculum, and it has all of what we're talking about today. It was beautifully written and includes many of these competencies we're going to talk about. But terminology like competency, what does that mean? I think you have to understand that before you actually move on to applying and so on. It used to be like this. And in my days, you'd follow around an expert for a certain amount of time, and when that expert felt that you were adequately similar to that expert, you'd get a stamp of approval saying that you are like me, and you graduate. And from looking at this group here, this guy here, I don't think is paying attention. This guy may not learn as much as these guys. And the concern is, that was the major concern, is why do we need to put it into a framework and to make sure that this person is getting exactly what this person is getting. This person might be excellent, but at least getting a standard that all of them receive. The test, again, well proven not to be enough to be able to label a physician competent. So what is competency? We started to hear terminology like independent practice to be labeled as competent. It recognizes there's a continuum of skill, that the day of your graduation does not end your learning. And then something measured. You have to be able to measure it. Just to say simply this guy is competent is not enough. And then you start to see terms like communication, in addition to the knowledge and so on, reasoning, emotions, value, reflection. If we could teach ourselves and our residents how to reflect, whether on a daily basis or after the end of an OR, after the end of a procedure, at handover. This is something, there are workshops now working on how to reflect and to be able to give feedback. And this has been shown to significantly improve the quality of patient outcomes. And this is why we do this. In our workshop, this term, the patient outcomes term, is thrown out between every sort of section because that is the whole objective, is to improve patient outcomes. So what is competency? It's an observable capability and ability of a health professional. It reflects a spectrum. And the spectrum meaning that this capability might differ for an R1 than an R5. And it integrates knowledge, skills, values, and attitudes. Multiple competencies can be combined, and they can be measurable with respect to a defined outcome. So you define, what do I want from an ophthalmology resident at the end of 5 years? What do I want from an R1 at the end of 1 year? Within these domains. And I'm sure the medical expert, you guys are expert, I'm sure your curriculum is clear on that. And the new curriculum shows very, very nicely what it means for a resident to be a good communicator, what it means for a resident to be a good collaborator, and how to assess it. And there are many ways to assess now than the written test. And just a couple of slides on, because I suspect you're going to be hearing about competency-based medical education. It's changing how medical education is happening worldwide, looking at outcomes, at competencies, rather than simply putting defined objectives from the beginning and see who will achieve them, versus clearly defined outcomes with milestones along the way. So these definitions, you'll be hearing them, is the domain of competence is those broad distinguishable areas of competence that in the aggregate constitutes a general descriptive framework for a profession. CanMEDS roles we just mentioned just now, or the ACGME. The 7 CanMEDS roles, for example, would be the domain of competence. A competency is an observable ability of a health professional related to a specific activity that integrates knowledge, skills, and attitude. This could be how to intubate an airway. For example, that's an easy one. It's a skill. Okay, it's not a professional communicator role, but just to give it what that might mean. But the milestone is that same observable marker of an individual's ability along a developmental continuum. Intubate an airway under supervision, for example. That will be defined for a junior resident. A senior resident might be required to intubate independently. And then you're going to hear this term, entrustable professional activities, or the EPAs. It's coming. Multiple competencies or milestones can be combined to produce an entrustable professional activity. The key task of a discipline that a practitioner needs to be able to perform. Manage respiratory emergencies. So intubate an airway might be a milestone within, and it's easy to assess, but when you combine it and to manage respiratory emergencies, that might include not only your technical skill, but your collaborative skill, working with the nurses and the OB-GYN, for example, if you're in the delivery room, or if you're in ICU, working with respiratory therapists and so on. It might have a communicator skill component, explaining to the family a child who might be in respiratory failure. So this is what an EPA would look like. So typically, each EPA integrates multiple milestones to provide that EPA. And several EPAs are now defined to be able to graduate. So for example, to give you at least perspective, I know again this is a very short time to do this, but to give you a little perspective, the American Board of Pediatrics now requires for you to graduate after 4 years with 19 EPAs. So you have to acquire 19 EPAs over the period of training. And within those EPAs, they have several milestones that you're checked off throughout your years of training. And that's where education is going. And again, that term I mentioned to you about competence versus excellence, we get this question often in our workshop. Well, there's no doubt that we do strive for excellence, but we have to demand a basic level of competence that all our graduates achieve, and help them achieve that. Sure, some residents individually might excel in a certain area. They might become better researchers or better educators or teachers or better surgeons. Centers might excel. In Canada, for example, Toronto excels in cardiac surgery. But it doesn't mean that it's any better, based on the Royal College standards, than a small program outside Manitoba, for example. The standards are the same for them. And this is sort of a graphic, sort of summary slide that we show to our attendees, that this was the concern, is that the medical expert was huge, and it's important. We did a good job at it, but this was a concern. And not only that, our local issues. We did not do a good job of teaching our residents even our local issues and concerns. And this is a slide that Dr. James Frank kindly shared with us about the concept of what we're trying to get across, is that we often were teaching our residents by osmosis. They followed us around, they watched us do things, and we hope that at the end of a month with my rotation in ID, or at the end of the year, or at the end of 4 years, we hope that they acquired the necessary skills to practice independently. And I often show our pediatric Saudi Commission booklet. This has changed, alhamdulillah, much better. But it just gives you perspective of how and why things had changed. When you open our booklet, it was a very small booklet. It was well written, written almost 20 years ago. It gives some general objectives about, describing a competent pediatrician who's knowledgeable. Again, a few paragraphs. They do talk about independently in a line. Do some research and professional, all this within a very brief paragraph. The specialty competencies are detailed. We talk about knowledge, the differential diagnosis of FUO or hepatosplenomegaly or so on. Clinical skills detailed, not much for us, but procedures and so on that you need and how to do a physical exam and so on. But the other competencies we talked about that everyone seems to agree that is important, that were mentioned in daily practice, how to teach it is not there, and that's a requirement now by the Royal College. If they come to visit to accredit you, or the ACGME does, or the Saudi Commission. I don't know if they visited you. I'm not sure, again, where ophthalmology is, but the Saudi Commission is changing how they accredit programs. They require that you show where you teach these competencies, where you assess them. And assessment, we were terrible at it. We did not assess our residents on any of these other competencies. Were they good communicators? They could be terrible communicators. And bad communicators resulted in bad patient outcomes. So why CanMEDS? There's so many reasons. I'm not going to go through all of them, but there are many literature talking about it. The patients that stay in our hospitals now are much more complex. When I was a resident, we had the luxury of residents staying with us, patients staying with us as long. We can work them up ala kayfna, just sort of take our time. However, now hospitals are telling us to push the patients out quickly. We need turnover. To do that, you cannot practice independently. You work with discharge planners, nurses, residents, and so on. And those who stay are much more complex, requiring, again, a multidisciplinary approach, and requires us to teach our residents how to work in this kind of environment. Things like service versus education. No more can a curriculum simply be put down based on where a resident needs to cover. And residents can, I think, relate to this very much. When a curriculum is put down, it has to be having an educational objective to every rotation. And the old man approach, simply me coming and saying, this is what the pediatric infectious disease curriculum should look like. That's not acceptable anymore. And this is a big one. Many of our residents, when they graduate, when we do our internal reviews, we actually do reviews, accreditation reviews, internally, based on the Royal College standards. We learn from them, and we do it internally in our programs. This is a big one for the residents. They're always concerned that when they graduate, and they know how it is now, that they're not prepared. We don't teach them to practice real medicine or even work in the private practice. It's a fact now that many of these will work in private practice. We don't give them the right skills for that. There's a huge evidence of need. I won't show all the literature, but I highlight a few for today's talk. I took out a few, but this is, for example, two large bodies in the United States, the American College of Physicians and the Association of Program Directors of Internal Medicine. These are very large, powerful bodies in education and training of residents. And when these bodies publish in the Annals of Internal Medicine a statement saying that redesign of internal medicine residency training was urgently needed, they're shouting, basically. They can't use more aggressive terms in the literature, but they're saying that something's wrong with how we train our residents. And this is, I'm sure many of you have heard about the Institute of Medicine report that came out, I think in the early 90s, showing the medical error and how much it contributed to inpatient mortality rates. This is a more recent report talking simply about diagnostic errors. This is the National Academy of Medicine, part of the Institute of Medicine report, showing that diagnostic error, and this is where the concepts of reflection and critical thinking come in to training of our residents and to improving their diagnostic ability. And I can't tell you how often we are in a morning report like this, and often our residents who do a wonderful job, they're working very hard, they're working at night, it's a difficult time for them, and they present their case of whatever it could be, a seizure and fever, and then you get the laundry list of, well, non-infectious, brain tumor, and infectious, and versus actually being able to critically look at the case and give a really manageable differential diagnosis and approach to the patient. A lot of competency gaps. And this slide I put up is a very telling. It was shared by one of our colleagues, Dr. Yasser Gazzaz. He's a pediatric intensivist who just got back from Toronto, and where they're applying competency-based medical education very aggressively. And this is the president of the American Board of Pediatrics who made a very critical statement, I think. And I take my board exams every 7 years. I have to recertify the American board. I just did mine last year. And he asked us questions: are we testing recall or judgment? And in our workshop, we discussed it with the residents. And the residents can really relate to the fact that they often feel they're being tested on their simple recall abilities rather than their judgment and critical thinking abilities. And he's sort of suggesting this sort of radical approach to exams is maybe we should, in our board exams, allow them to access resources, because this has become a fact. When I'm rounding with my residents, when I talk about give me the management of tuberculosis, some of them are sitting in the back on their iPads or their phones and looking up from the latest textbooks or papers about the management of TB. And that's fine. But the point is, that's not what my residents could easily tell you how to manage tuberculosis. But if I told them that this patient comes from outside Riyadh, or this child is unable to take pills, or the family is divorced and the mother has no transportation, and so on, how they could deal with that. Yes, it's easy for them to write a prescription and send the patient out, but that results in patient failure or therapy failure. How they deal with nursing or discharge planning or the administration, or they're going to have to fight or advocate for the patient, call the pharmacy, we need suspension. It's part of what we do. And if you can't do it alone, who can help you on a team? Is there someone to help? These are all skills that they can learn over their years of training. And hopefully by the time they're seniors, they become very good at this. And a patient who comes in with complex issues does not become a challenge for them. And patient outcomes do not suffer. Saudi Commission is doing it. It's done. Your curriculum, again, I saw it when I gave the workshop to our residents. We touched upon it a little bit. Very well written, and I hope it becomes applicable and applied. Morbidity and mortality concerns. I was the chairman of morbidity committee for 3 years at the National Guard, and I can tell you, in an indirect study we did, sort of, and we didn't publish it. We just wanted to see why all these morbidities were coming in. And I can tell you close to 70% of the things that came to us had nothing to do with pure medical expert issues. Surgery's gone wrong, or it was almost all of them were communication issues. Patients not understanding what was going to happen to them, consent issues that were taken inappropriately or wrongly, things like that. Things that almost many of them would not have come to us had patients had better communication and relationship with their physicians. And it made a difference. It made because the patients stayed in the hospital longer, it was a huge time burden on us, and so on. These things accumulate. Our society is concerned. We see this. I think all of you agree. I felt it. All of us have felt the impact on how society perceives how we're practicing medicine. And when you start seeing, I put this caricature here, in mainstream media, في جريدة الرياض, you know that there is something out there, justified or not, that there's a concern out there that we're not addressing. We need to be better at it, talking to our society and finding out what's wrong. I just wanted to highlight that it's not just, when I'm talking about CanMEDS, that was just by chance. There are many reasons, but why the Saudi Commission is using CanMEDS. So the whole world is having different formats. And again, it's not, the science is not complex. These are things that these bodies simply put into a better framework, and things that I'm sure many of you as educators are doing every day. And I give examples in our workshop when we have time to do. So the hope is that these skills, roles, competencies, as you mentioned earlier, are translated from abstract concepts. It's easy for us to talk about it, and our job, often this kind of lecture workshop is there's no doubt, it's theoretical. The workshop is more hands-on. Many of those who come to our workshops take away some tools that they can actually use, some assessment tools. We do our introductory workshop for the full day for all the roles, and we do an assessment workshop that many of the faculty can take away with them. But unless we can take the idea that it's just simply an abstract concept, then we failed. It's easy for me to come up here and talk. But change them into concrete behaviors, whether on and given feedback. The smallest, and I found it unbelievable that they did this. If we were this reflective on what happens on our day-to-day practice, and our industry is very different than the airline industry. I understand this. We deal with patients, and patients are very different. But the concept of at least looking at how we do things, and when is it that we've maybe not done things the way it should have been done, and maybe correcting the path. I always use an example. One of my colleagues, Hatim Jifri, he always says, there might be a surgeon who has 20 years of experience, but if nobody has told him that he's been doing something wrong, he's simply been doing something wrong for 20 years. It doesn't mean that he's a great surgeon. allocate health resources. This is just all under the leader. Set priorities, manage time. I cannot imagine or tell you how often we talk to our senior residents. I'm not sure in ophthalmology, but in pediatric, senior residents are team leaders. They have juniors tahtahom and interns and students, and we round with them, but our rounds maybe 2 hours, maybe 3 if it's a long day, when we're physically with them on rounds, starting after morning report. By noon, we're done, but then they're taking over. And you can tell the difference between a resident who's عنده موهبة, talent to do this, versus those who struggle. Now, unfortunately, now we're beginning to try to teach our residents to manage their time and how to delegate, and we give them a few lectures and workshops and time out, bring in some colleagues from the administration, however we can do it. But the idea is that they need it. The scholar role, as scholars, physicians demonstrate a lifelong commitment to reflective learning as well as the creation, dissemination, application, and translation of medical knowledge. So, continuous enhancement of professional activities. So this is the lifelong learning concept. Learning of students, residents, and the public, so the teaching ability. Our residents, like it or not, they teach, even on an individual basis. They'll teach a patient how to use an inhaler. They can do it well, they can do it poorly. Not to mention they might have roles in teaching the interns and students, and when they graduate, they're going to be teachers. And we teach, most of us do. And the impact of the hidden curriculum, for example, and its role. And then, feedback. This is the one I always highlight. This one. هذه الحالة, again, there are several workshops on how to give effective feedback. If we could have, and it's a cultural thing, and many of you may agree, at least in our Saudi culture, I struggle with giving feedback. I struggle giving negative feedback. It's not easy for us for cultural reasons. And again, there's not enough time to talk about it, but evidence-based medicine concepts. And then be able to critically evaluate integrity, reliability, and applicability of health-related research. Again, the ability to critically evaluate research. A lot under the scholar. The collaborators. Collaborators, physicians effectively work within a healthcare team to achieve optimal patient care. So it works with physicians and other colleagues in healthcare professions to prevent misunderstandings, manage differences, and resolving conflict. This has now become standard, part of residency education in many programs now, that residents are trained how to manage conflict. And conflict happens. It's something, and actually many institutions welcome conflict. When the ER doctor is calling radiologist saying we want a CT, and the radiologist says, no, I don't want, I think there's no indication, how to resolve that, how to approach that, how to understand various differences in approach. Transfer of care. I can't tell you how important this is. I'm sure as a tertiary center, you often receive patient transfers. And I'm sure in our workshop, our residents give us examples of good patient transfers and how it has a good impact on the patient you're taking care of versus 2 or 3 lines from a referring hospital. Please take this patient. And how it has an impact. And handover. Handover is a science now. I don't know if you do handover, but end of day or morning handover has become a science and has been shown. Poor handover results in mistakes. And the professional role. As professionals, physicians are committed to the health and well-being of individual patients and society through their ethical practice, high personal standards of behavior, dedication to the profession, professional-led regulation, and maintenance of personal health. This is an interesting addition that doctors have to take care of themselves. So commitment to patients by applying the best practice and adhering to high ethical standards. Conflict of interest. Residents are going to be bombarded with conflict of interest issues. Unless we teach them how to deal with that, it can result in a physician who struggles. Commitment to society, or accountability to patient, society, and the profession. We have to understand that there's a social contract between us and the society. Yes, they have rights, but we also have rights, and there's a contract. And there is actually. If you go to the Ministry of Health, I was very impressed by the Ministry of Health, لائحة تنظيم الممارسين الصحيين. It's a beautiful document, actually. It talks about many things, حقوقنا إحنا, many of them that we actually don't exercise. This one I was talking about, you'll find it on the Ministry of Health website. And then physician well-being. We have to be careful about our residents and how they understand that they need to take care of themselves, understand stress and burnout. And it's common. The highest in anesthesia, for example, have high burnout rates. And it's a sad thing when a resident who's gone through medical school, many years of medical school, a few years of residency, it's a long commitment to lose them to something like this. The communicator is a critical role, as I mentioned, that relationship between the physician and the patient, and so many enabling competencies that go under that. Encouraging patient trust and autonomy, empathy, respect, compassion. This is what I was talking about. Often, many of the complaints, you could almost take this, بالعربي, in Arabic, and put it in the complaints that the physician did not show this to me, did not express any respect to me, and so on. This is not a mistake. They were just simply unhappy with the outcome, which is a normal outcome often, but this was the concern. Issues of nonverbal communication, nonverbal behaviors, they're so important. Teaching residents, especially in our society, how to respect elders and so on, and dealing with children, and respect for the gender differences and so on. Be able to take a good history is critical to that communication skills, part of that. The structure to manage the flow of the entire patient encounter from the greeting to the summary. And there are actually ways of doing that. They're actually structured, nice. You may have heard of these models. Any of you who do any type of communicator workshops, the Cambridge-Calgary model or Kalamazoo models, these are nice models that, just like how you do an LP or any of your procedures, it shows you the instructions on how to do a good communication session. It doesn't talk about the details of what the history for ophthalmology may be different for pediatric ID. But the way we take the history should be the same. And whether it's a 2-minute history in the ER or a 15-minute history in an easygoing clinic, the procedure is the same. It's very interesting. Sharing information with other colleagues, that's part of the communication, and the family members. The written health record, it's part of the collaborator, but it's critical. Having good notes and good transfer notes. And the health advocate, as I mentioned, health advocates, they contribute to their expertise and influence as they work with communities or patient populations to improve health. They work with those they serve to determine and understand needs, speak on behalf of others when needed, and support the mobilization of resources to effective change. I was very, we had one of our conferences, our education conference in the National Guard 3 years ago, and the president of the Royal College came and spoke. And he's an ER physician who's very interested in trauma, accident prevention. That was his interest. Motor vehicle accident and road traffic and prevention of accidents. And he read a lot about Saudi Arabia before he came here. He asked us a few things, and then he gave his plenary talk. And he spoke about how in Saudi Arabia, considering our population and the relatively young population compared to the rest of the world and so on, that he suggested that we could have an ER admission rate of 0. That was, of course, very ambitious. But he was saying that most of your problems come from what? Anybody knows the ER visits? What's a huge, big ER visit? Road traffic accidents. That's huge. A big percent. I forget the numbers. And that's preventable. And complications of diseases that need not come to the emergency room, like you guys see that. What's a big disease here in Saudi Arabia? Diabetes, that need not come to emergency rooms. He was talking about the emergency room. He's an ER doc. That most of these could have been managed, if managed better, in the outpatient setting or in primary healthcare setting, if the physicians took care of these things in a better way. And heart disease. And he was talking about heart disease and the smoking issue, and how he was surprised at how much smoking and undiagnosed hypertension, that were all issues related to advocacy and community work. Had nothing to do with these huge tertiary centers that we do a good job of, but unfortunately, I think you feel that too, that many of our tertiary centers are a bit burdened with issues that may not necessarily relate to the mission of these tertiary centers. So again, there's several key competencies that go underneath those. I won't go through it in detail. So these are just a list of so many possibilities that can be used as teaching tools. And usually when we have time, we go over each one of them as an example, and we have models. We have a few now, but I think I'll stop here. But there's so many ways that can be used. And again, the integrating, not adding, many of these can be integrated into what you do on a daily basis. And focusing on, again, the medical expert is a critical part. But if you include, I'll give an example. The internal medicine and in Haras, they have morning report every morning. But one morning, I forget which day, but one morning they asked the resident to present the case, status asthmaticus or whatever case that came in, but they don't present the medical expert part. They present and they put it on a table that this patient came with status asthmaticus, what was a collaborator issue with this patient, that we needed to talk to ICU, nursing, respiratory therapy, was there a problem, and then, okay, what was the communicator issue? The family was difficult to deal with, and they discuss it. They deal with the case like they do in a morning report, but instead of dealing with asthma and steroids and what's the most appropriate treatment, et cetera, just that day, they talk about the the intrinsic roles of the CanMEDS competencies. So there are several ways to teach and to integrate. It's not easy, but with time, similar to the research role that we've now, I think, done a fairly good job in getting our residents involved. They talk about research and its concept much better than I did when I was training like them. So I'll stop here and take questions, or there are a few slides about teaching and even assessment, but I don't think time will allow. So I'll stop here and thank you very much for having me, and if there's any questions, I'm happy to take them, Annie. Thank you.
Thank you so much, Dr. Essam. Among the 6 domains of CanMEDS, which one you think play the most important role, the most important? Well, in your personal perspective, point of view.
That's a difficult question, to be honest, Yanni, because you can see they intentionally made the flower. The medical expert is essential. I mean, if you don't graduate an ophthalmologist who knows, again, I'm not an ophthalmologist, but knows the anatomy of the eye and knows how to treat glaucoma and do your laser stuff, and that's a problem. You need to do that. So the medical expert is critical to that. I think the Royal College and the ACGME, if you listen to the Americans when they come and talk about it in the conferences, they highlight that they don't emphasize any particular role, to be honest. They emphasize that they are all weighted towards graduating, and that's why the Royal College puts that flower. I often look at it more rather than important, rather than how applicable it is and how quickly you can make change, and how, because it becomes imperative for us to make the change. If you tell me some of the things you saw here, I'm sure were difficult. Some of the professional role I find is one of the difficult ones to teach and to assess. But however, the communicator role is something that I'm sure many of the educators practice. Some of the residents are excellent at it. It's just not in a proper framework and probably not taught and assessed in a structured way. I would probably say that you should probably focus on what you already do. And maybe start implementing those. Those are quick wins, Asamihan. I'm talking practically, Lanya. Theory is important, but for practical purposes, rather than what's important, what is it I can apply quickly? And what is it that you probably already do that you can actually put it more structured and start to teach it and assess it in a very quick way? Within a few months, you could already have many of these part of your curriculum in a structured way. That's the best answer I can. I don't think anyone is particularly.
Sometimes when I look into these 6 domains, I have a feeling that the communications and the collaborations and to become a leader is one of the things is play very, it's so variable between individuals. And some of our colleagues, they are really talented.
Yeah.
You can tell from the first day that they are gifted. And others, very difficult to predict about their, So what is your comments about this?
It's simple. I mean, the slide, if you recall the slide, the competency versus excellence slide. I mean, the idea now is that you have to demand a certain level of competency. So when you come to the communicator, a resident who's not I'll just use broad term, not a good communicator, you have a curriculum that teaches communicator, and then you assess them on that. You have to have assessment. And if you assess them on whether it's, I can put out the assessment tools, and there's a nice workshop done for that, work-based assessment on that. And you assess that resident, and he's not meeting that standard, then that resident should not move forward. And when I say move forward, the term fail is not being used very often now. The term competency-based medical education is that what you'll be hearing. So a resident has a milestone to achieve. This resident is able to break bad news based on your standard, appropriately or acceptably, or however. And the definitions are now defined for the Royal College and the American Board. They don't have Likert scales anymore. They don't have 1 to 9 scales. It's competency. So under communication skills, the resident is able to, an R1 or junior resident is able to inform the parents about a simple management plan. And you check it off as an educator, if they achieved it or not. If they haven't achieved it, you don't check it off. They don't move forward. They just need more feedback, more teaching. And they might end up failing because of that. But that's the approach now, is that that resident who's not, now there are some who will be excellent, who would achieve it quickly, and that's where part of competency-based medical education, and part of our talk, which we don't have time for today, talks about that. In some programs now, they're suggesting that some residents can go through programs faster than others, which to me is not that important, and I'm not sure that's something very, in Toronto, the orthopedic program is now fully CBME, and some residents are graduating earlier than others, but others are taking a little bit longer. And it's not considered a negative, it's considered part of the training that, well, he hasn't achieved the competency, he's not communicating to the standard that we have. We give him feedback or remediation and try again. But they have to achieve that competence. And that's the point, is that we should not be graduating residents who don't meet our standard. وهذا كان يحصل أول يعني. If he passes the test, I can't imagine, I tell you how often we sit in meetings and we have our Likert scale. resident معانا صار له شهر في الID. And we have the 1 to 9. And it's just a few. I have a copy of our ID rotation evaluation form. And we sit there struggling. طب كان 7 ولا 8؟ واحد يقول 6 لا 6. What does this mean? يعني? It has no meaning to us. But when it's a compliment, I know that at the end of the month he has to have shown that he can write a good response to a consultation, can communicate with patients. I watch him talk to a patient, sit there and watch him talk to a patient about management of tuberculosis in the clinic, and then I can check off that he can manage a complex patient. This is the way we should be going, and the rest of the world is going.
Yeah. Any questions? Yes, Dr. Abdullah.
Yeah. Thank you for this nice comprehensive lecture about CanMEDS. My question is, just want to go back to the, because we are in this field for a while.
Yes.
Want to be more realistic in implementing these changes.
I will bring the mic inside that.
In multiple levels, university, in Saudi Commission, National Health Hospital, there are moves to change, and these changes happen over the last 40 years.
صح.
In my opinion, these are a quick shift that may not end up with a good result. So, my opinion, we need to prioritize things, especially in the assessment level, and implementing the new medical education tools. We cannot come to the people who are just started the CanMEDS implementation, then we request from them the new assessment tools, and then they will be overloaded they will be overloaded with all these things, and then we'll end up with poor outcome. So what do you think about
No,
it?
I agree, and you just heard my comment. I don't know if you heard me say, I think the quick wins are important, and you have to prioritize when Adil سألني عن which one is more important and so on. I think programs have to look at what they can do on a short term and long term. On short term, there might be things, I suspect, إنه عندكم أشياء ready to go. يعني you probably do it, you just need maybe to modify it شوية to meet some of the criteria. But no doubt, you cannot, the Royal College, شفتوا, and it's been over 20 years they've been working on this, and they're still working on it. However, I think if the Saudi Commission does not make it part of accreditation, it's not going to happen at Dictor. Royal College, this is what they did. They made it part of accreditation. So what the Royal College does, they come to you, and if you do not teach the professional role or assess it, by the way, you can do it any way you want. This is different in the Saudi Commission. يقولوا هذا لازم تسووه. For Royal College, they don't. Toronto teaches professional, very different than Ottawa. Very different than the Texas Children's Hospital or the Boston Children's Hospital. But they come and they need to see evidence that you teach the professional role. These points اللي قلناها مثلا. And you assess it. So you show them, well, we give a lecture on professional role or a workshop. We have role play sessions, simulation sessions on professional. Residents are in Toronto, R1s are required to write a reflective paper on the professional role in Canada. For example, portfolio, that's an assessment tool, by the way. And you need to show that you assess it. And if it meets that standard, they say you meet it. So the point is that, and I agree that the Saudi Commission saying this is how you have to do it could be tricky, because a small program في منطقة من مناطق المملكة may not be able to not have the resources to do it that way, but they could do it another way. And I believe that the things that you're hearing here are very doable. ما هي أشياء صعبة جدا. With the talent we have, I've seen very innovative. يعني, for example, I was in Jeddah, giving a workshop in Jeddah with pediatric dentistry program have now implemented. ورتني الدكتورة ما أعرفها أنا شخصيا. She's a program director of pediatric dentistry. For the professional role, which is very tricky, they've implemented something you may have heard about, 360 degrees multi-source feedback. They implemented it now. They have, for every resident, twice a year, they send this form, which has about 8 points on it, to the dentist عندهم الاسيستنت حق الدنتست لازم هذا التكنيشن الراديولوجيست وستاف والريزيدنت نفسه. They fill out their multi-source feedback form that includes some of the professional things, on time, ethical, honest, كذا وpatient. They give one to the patient twice a year بس يسوونها. And it's working. And they do about, for each resident, about 6 to 8 papers يعني أشخاص. And she ورتني الأشياء. This is very impressive يعني. هذا يعني it's a pediatric dentistry program. مع كل احترام لهم يعني. قصدي what I'm saying is that they're not somebody who's involved heavily معانا في السعودي commission زي الميديسن ويمكن أنتم وكذا. فأم saying إنه it is doable. You might have your own ways of doing it. Starting small is fine. I don't think, and I agree that Saudi Commission has to be careful. And faculty development. حتى في الرويال كولج they invested heavily يعني heavily في الكلينيشن educator program. عنده حوالي 7 أو 8 احنا نحاول نسويها لكن we're struggling احنا صراحة for many reasons يعني هذا شيء موضوع آخر. But they have a clinician educator where they go to Toronto, they go to Ottawa, and they give workshops, 2 3 day 1 week workshops. فيطلع الفاكولتي من workshop معاهم tools. يمكن ما هي perfect لكن على الأقل خرجوا بtools يبدأ يطبقوها. It's needed. And هذا دور السعودي Commission دور اللي مستعد وإحنا happy to help as much as we can. But without faculty development ما صح. You cannot give faculty form جديد DOPS ولا mini CX يلا روح examine her resident. That's not fair.
Exactly. With the load of the patient and with the service needed in our community, it would be difficult to implement all these tools. I totally agree of prioritizing, maybe doing this step by step, and then inshallah we'll end up with.
But your curriculum ترى حق ophthalmology أنا عدته it's very well written صراحة, very impressed صراحة يعني. فإذا استطعتوا تطبقون أجزاء منه تدريجيا I think it's a great achievement يعني. I think.
Thank you so much, Dr. Essam. We ran out of the time, so.
Thank you
It's
very
the
much.
time for the quiz.
My
Thank you
pleasure.
so much, Dr.
شكرا لكم.
Thank you.
معك.